I'll tell you what, while we're waiting for this to get started, we'll have a little mobile health in action experiment. I was supposed to be the lunch speaker.
It's our technology.
And I wanted to actually show this before you ate, but if I could ask people if they have a cell phone, regular old plain old phone, nothing fancy, to send a text message with the word BMI, just BMI, to a phone number, a short code 311411. So if you text BMI to 311411, ideally before you eat the brownie in your lunchbox, it'll basically, if it's too late, sorry, I was hoping to intervene before that, but if you text the word BMI to 311411, you'll have a live mobile health experience to make some of what's on PowerPoint actually seem a little more real. Let me, it's still tricky. Now, I was invited here to talk about what's going on in mobile health around the world, which is something that we at Loxiva have been doing for the last 8 years. Loxiva, we're based here in Washington. We work in about 13 countries around the world, mostly in the developing world, where frankly a lot more innovation is happening. Because they were rapid adopters of mobile phones, there's just a lot more innovation in our view in mobile health and applying the ubiquitous mobile phones to health. But I couldn't resist coming here to Capitol Hill. I couldn't resist the chance to talk a little bit about what's going on with the implementation of the stimulus package in health IT, because it's obviously a pretty significant time in health IT here in the US. There are a couple, two basic principles that I would encourage, particularly decision makers thinking about how to invest a lot of money in health IT right now, to keep in mind. And it's been echoed through the morning, but the first one, which is to be sure that health IT actually reaches people. I think so much of the discussion around implementation of health IT is about servers and clinics and what's happening in the back end. And not about actually reaching people. And also, as has been echoed throughout the morning, be sure that health IT actually improves health. So this is a diagram of what is called the National Health Information Network. There may be a more recent version of this, but this is sort of one of the sort of central tenets of the plan for investing money in health IT. And I look at that picture, and I have the question of where are the people? This looks to me like a lot of buildings talking to buildings and a lot of servers talking to servers, but not actually connecting people. I heard a great analogy from someone from the California Healthcare Foundation who likened what we're going through now in health IT. He used the example of the book industry, and he sort of did this thought experiment. He said, imagine if 15 years ago the government had to spend $20 or $30 billion to bring technology to the book selling industry. What would they do? Well, they'd probably go buy computers and software and internet connections for bookstores. But they probably wouldn't have thought about investing in Amazon.com or the Kindle. And so I think it's just really important, as we are about to spend all this money, that we avoid just wiring up the bookstores. And we actually think about how can technology be introduced in new ways and how to support new business models, many of which you've heard about earlier this morning, that actually can transform healthcare. And so health IT doesn't basically just sort of lock in an existing system and sort of automate what is clearly a broken system. I think that's the big danger, is that we use health IT and it just locks in and reinforces the existing broken system, rather than thinking about new models and actually using technology itself to make people healthier, which I think too often gets lost in the discussion of health IT. You've heard this sort of ad nauseum this morning, the costs of spending in chronic care. And Be Well and others have talked about the importance of compliance, and how actually, if you can actually improve compliance, you can vastly reduce costs. So I think a very important area to focus on is how can health technology focus on improving compliance, thereby improving health and reducing costs. sort of ask the question of, if you ask the question, how can health IT reach people, let's start with what kinds of technology people actually have. So you've got about 73% of adults that have internet access. An amazing statistic I found in preparing for this from the Pew Internet American Life Project, of people with chronic conditions, only 50% of them have internet access. So again, if we think about reaching people with chronic conditions, only 50% have internet. So clearly we need to think beyond the internet. Obviously you can see where this is going. Mobile phones are far more ubiquitous, almost 90% of Americans. 600 billion text messages sent last year. One of the other really interesting things about mobile is also the demographics of its use. If you actually look at both income and ethnicity usage, you actually see a higher proportion of data use in lower income and minority populations. And so if we think about, for example, how to extend the reach of health IT services to underserved populations, mobile is an incredibly useful tool to actually cast a much broader net than traditional internet solutions. What is mobile health? I tend to think about it in three categories. Well, first, sort of the provider-centric solutions, where you're supporting, whether with a fancy device like you saw from Craig Barrett this morning, but you're supporting providers and using mobile technologies that providers can use. If we think about the people side of the equation, again, I divide it in two. I think about sort of device-specific solutions, whether they're the home health devices that we saw from Intel or the glucometers. On the other side, and this is where we focus, are on patient-facing solutions that are actually leveraging the mobile phones that people already have. Because we've worked in the developing world for so long, we really think about how to create solutions that leverage the things that are already in people's hands and in their pockets. I mean, in our work in Rwanda, in Peru, wherever, you can't think about buying a new device for someone. You can't give an HIV/AIDS patient, a fancy iPhone. You have to make do with what's already there, whether it's the payphone they can walk to, whether it's the mobile phone they can have access to, and so forth. So we focus a lot on solutions that leverage the technology that people already have to communicate and interact with them and engage with them. There are all kinds of opportunities that, many of which we've already talked through this morning, from adherence and wellness, but in broad categories, I think you can think about these kinds of mobile health solutions in helping keep people from getting sick, like prevention wellness, and then helping people who are sick get healthy, kind of chronic disease support and so on and so forth. But within those, there are many categories of use cases. So this was supposed to be the thing that we did before lunch. So some of you may have been through this by now. If I actually get on the internet, let me just log on here a second. So I'm not logging into sort of the back end of an application that was for the people who were going back and forth with that SMS. This is what you were interacting with. So here are some people who have actually been doing this. Let me, so I don't embarrass anyone with their weight and height right now. This is actually the data that you've just provided through that interaction through SMS. So again, part of my point here is we can talk about all sorts of exciting new devices and so forth, but there are 270 or 80 million cell phones that are in people's pockets today that can actually be connected and start delivering solutions today. Then if I actually go here, let me find myself. It should be in here. Anyway, the point is, we can monitor in real time, we can look at data, and we can communicate and interact with patients. And hopefully, if some of you haven't already eaten the brownie, and you realize that maybe your BMI is a little higher than it should be, maybe you will not eat that brownie today. And that would be an example of mobile health changing behavior. I mean, everything we talked about here is how can technology change behavior to reduce costs? Hopefully, in this tiny little experiment we did, by telling you and interacting with you through the phone in your pocket, we've been able to keep you from eating that brownie. So maybe it worked, maybe it didn't, but again, just an example. So let me switch over. There is a lot of evidence, and I think you heard some great evidence from some innovative studies that BeWell has been part of. There's increasing evidence about these kinds of even simple interventions with just text messaging, as you just went through, whether it's with diabetes or smoking cessation or other examples of how mobile health solutions have actually improved health, and primarily by improving compliance. There are actually 184 studies. I won't go through all of them in detail, but these are the summaries of 184 studies. Now, most of these have been done in the rest of the world. I think the U.S., as I said earlier, beginning to catch up and sort of wake up to this mobile revolution that the rest of the world has been adopting. There are some, I mean, these are some of the things I'll talk through in specific details, some of the things we've been part of. In Rwanda, health workers are using mobile phones to register patients, report symptoms, access lab results. In Mexico, there are applications where diabetics are using mobile phones to report glucose levels. In Peru, which was the country we first started in, health workers report outbreaks of disease, track distribution of drugs, and so on and so forth. Why has the rest of the world been so quick to adopt? This is actually the adoption of mobile phone technology around the world. There are now 4 billion as at the end of the year. The reason that I believe that the rest of the world has been, in some ways, moved ahead of the US is out of necessity. The internet isn't a reality for most developing countries. The mobile phone is all they've got. And so a lot of the things that we here think about using the internet for, the rest of the world goes straight to mobile and thinks about how do you leverage those 4 billion devices to solve many of the information problems that here in the US we would think about using the internet for. So those are some of the reasons why I think the rest of the world has jumped ahead. Let me just skip down a couple slides and talk about non-invasive insulin. Just jump ahead quickly. When we first started 8 years ago, we started working in Peru in health, and basically started working with the Ministry of Health. And the problem they had was information was very slow flowing up and down through the health system. And people and health workers used to fill in paper forms and they would send them up, and it would take a long time for health authorities at multiple levels to see the information, make decisions, and so on and so forth. Obviously a little bit like our paper-based health system here in the US. And so we implemented a system that let people use phones to report and access information directly from a central server. So let me play a quick video here describing some of the users. This works.
This is our technology, this plastic card, that itself, because you don't need any other thing rather than this in the farthest place of the country, and they have short instructions in order to use the telephone to dial into the network and then to submit the information.
Los beneficios de Oxígeno para nuestro establecimiento de salud fueron la posibilidad de nosotros poder indicar los casos notificables en forma rápida y oportuna.
Pero como la gran mayoría se pasa llenando la información, en algún momento hemos evaluado y hemos considerado hasta un 40% del tiempo efectivo del trabajador de salud para completar todas estas actividades administrativas que están relacionadas con el
Esta productiva me ahorró bastante tiempo, o sea, tanto en calidad, tanto en horas que para mí es bien necesaria.
So just to be clear, this happened in Peru.
The only solution is networking. Networking the resources that we have so that we improve access. And that's part of what we're talking about, especially when we get into the issue of wireless. We've already heard about the acute versus the chronic care issue, and that most of the money is spent in terms of chronic care. I'd like to expand on that just a little bit by saying that statistically, somebody in this audience has high blood pressure. Statistically, somebody in this room has diabetes. Statistically, somebody in this room has all kinds of chronic diseases. The issue is not just taking care of old people at home. The issue is taking care of people with chronic disease who are at play, at work, at school, who are being productive. And it's taking care of them and allowing them to care for themselves where they are and when they need it. And that gets us into this issue of coaching that has been discussed. Let's talk for just a second, before I get into my presentation, about what a coach is. For a number of years, I coached soccer at the local YMCA, boys and girls 8, 9, 10, 11 years old. I would spend Tuesday and Thursday evenings teaching them the rules of soccer, the moves of soccer, making certain that they knew how to make those moves, making certain that they knew when to make those moves. Then the game came on Saturday. What did the referee do to me? I was the coach. What did he do to me? Silence. The issue was not whether or not my kids knew the rules and when to use them and how to use them to make the moves. The issue was whether the kids did it on their own, in the field, in real time. And one of the things we haven't talked a little bit about today is that healthcare is a contract where, particularly in chronic disease, there is responsibility that has to be assumed by the patient. It's not just reminding them, because you can remind them as long as you like if they don't take the responsibility to do it. It's something else we're just going to have to keep in mind. But, I'm sorry, I'm going to press the wrong button. There we go. Please remember that I have the privilege of representing a lot of people. I'm an endocrinologist. I'm technology familiar, but I'm not technology expert. What I'm interested in is applications. Every application we get involved in involves partners. I have the privilege of speaking for these people. Let's remind ourselves that telemedicine, as we've talked about it, is just the use of medical information or patient information exchanged electronically to get the business of healthcare done. The term telehealth was taken because people kind of stole this to mean just docs. And it's not just docs, it's everybody. It's administrators, it's non-clinicians, it's clinicians, it's patient. It's just doing all the things that we do in healthcare. So I use these two terms interchangeably. The key is that from an applications and from a clinical point of view, what we're talking about today enables individuals of any health discipline to do three things. And that's to provide required health-related services to those who need them, and this is the key, where and when they need it. But don't forget the patient size, because this is what about the internet and about telecommunication is really going to revolutionize healthcare. It becomes a consumer issue. You demand access, not during office hours, but as they're needed, where they're needed, and when they're needed, as we're at school, at home, at work, at play. So the question has never been about telehealth, is whether we can make the current system work more efficiently, quicker. The real question and the real challenge is how we can use these technologies to do things in healthcare that would have been impossible in the era before telecommunication technology. That's where the challenge is, and that's where the excitement is. We can talk about all the issues of technology. And depending on the application you do, you need more bandwidth, you need a different kind of box. You might be in a building or you might be at home. That depends on what kind of application you're using. The real issue is mobilizing both the patient and the provider and making it happen in the mobile environment. I need, therefore, to talk to you about two different kinds of healthcare. Remember, I'm speaking as a physician. So one of them I call acute, or the original telemedicine idea was consultative, where you didn't have experts everywhere and you needed to project the expertise out. And what you did was project the expertise from specialists to assist primary care providers making a diagnosis and developing a management plan. And by doing that, you elevated the level of practice that was occurring in a primary care or rural underserved environment. Georgia now has a statewide telemedicine system for doing that kind of health care. It's wired, it's connected, it works. But there's a lot of things that it can't do. Let me give you a couple of examples. And with this, I'm partnered with our Department of Neurology. Strokes. If you're having a stroke, you have 3 hours to stop the ischemia to the brain before there's damage. In order to do that, you have to give a clot-busting drug. They're available. But there's 2 kinds of strokes. There's an occlusive stroke, where the clot-busting drug helps. And there's a bleed stroke, where if you give the clot-busting drug, you actually make the situation worse. So you have to have some expertise to be able to decide, is this a go or a non-go situation? And that requires that the neurologist be available instantaneously whenever you need it, not just in office hours, and not just when he's in the hospital. And that's where we've developed a system that allows the neurologist to interact with the patient, get the data that's required, see the film that's necessary in order to make the diagnosis and make the go or no-go decision. And it works. And it's being deployed in many areas. That's 3 hours. And that's stroke. But think about heart attack. Wow, if we could do this for people who are having heart attacks, 15 times, 20 times as many people as are having strokes. Because there's another problem with heart attacks, and there's my partners for that. In heart attacks, you have 60 to 90 minutes. And that gets into the issue of moving patients somewhere. I was attending a meeting in Atlanta. It was 8 o'clock in the morning. The meeting was supposed to start at 9. I was on 285. I could see the building. I called them on my cell phone and I said, look out your window, I'll blink my lights. I can see you, but I won't be there in time for the meeting, because we were in gridlock. The issue isn't how far away the healthcare is, it's how long it takes you to get there. And it could be across the street if you can't get there and be inaccessible. Georgia is not a good state to have to live if you don't want to have a heart attack, especially rural Georgia. The treatment, the primary treatment for a heart attack is to get a catheter into your vein and get it up there and bust up that clot. That's the preferred treatment. It's got to be done within 90 minutes. Those are the locations, those are the counties in Georgia that have facilities to be able to do that. Heaven forbid you live here. Even worse, let's put it this way, the gray counties have no cardiologists. Not only that, EMTs are required by law to take you to the closest hospital. Well, if the closest hospital doesn't have the technology to do the testing, what good does it do? So we have the problem of travel time for the EMS. We want to do this procedure, but if we can't get the patient to the right hospital within 90 minutes, they're going to die. Is there something else that could be done? Yes, we could give thrombolytic therapy. It's a second choice, but it's better than not being able to do the first choice. But once again, we get into the same dilemma we have with the neurologist. We have to give it to the right patient. What the cardiologist will tell you is that they have to be able to read a 12-lead electrocardiogram. 24 hours a day, 7 days a week. So if you want to do this, it's not whether or not the drug works. It's not whether or not the EMT can get to the patient in the hospital. It's not any of these factors. It's whether the cardiologist pushing a shopping cart in the supermarket at 8 o'clock at night with their kids can get a phone call and read that 12-lead EKG on this device. We've talked about cell phones. None of this is worth investing in if you can't do this. And there are a lot of systems that get the cardiogram and get it to the hospital. But that's not the problem. If the farmer is laying in the middle of the field and the EMT got there in 30 minutes after the call, you've still blown 30 to 60 minutes. The EMT's got to be able to give the drug. You can deploy the drug if you can read the cardiogram on this. So that was the question. And actually, we've just finished with this study, and this was the question: could they judge it? We did the study in the classic research way of doing a gold standard, finding out what they look like if they got the chance to look at it on paper or with a big computer screen. But then we tested the cardiologists using this. They got all of the myocardial infarctions written, and they did better than 95% in a lead by lead by lead by lead read. We now know that we can use a cell phone to deploy the system. That's how you can use it. That's how you can use wireless. But let's say you have a kid who's really sick, and he's not in one of those hospitals that's fully equipped with the connections. And we have to take advantage of wireless technology. There's a problem. We don't have enough physicians trained to provide critical care services. Clinicians frequently find themselves someplace, let's say me here, talking to you when a critical call comes through. Medically, it's very rare that the clinician has to look at the whole picture. I don't need to see the whole room to be able to see your face. So the question was, could we figure out some way in a situation where there was a limited bandwidth to allow the clinician to see what the clinician needed to see? Zoom doesn't work. For me to tap on the screen and say, this is the part that I want to see, and increase its size doesn't work because Zoom doesn't change the amount of information that's there, it just blows it up, so it's not clear. So working with partners at Georgia Tech, we've developed what's called region of interest technology. Built into the cellular device is the ability to redirect bandwidth. So even though this is what the picture is supposed to look like if I had plenty of bandwidth, and this is what it looks like when there's not very much bandwidth, but all I really want to see is the baby's face, then I should be able to just tap on the baby's face and then have the cell phone redirect the bandwidth that's available to put the clarity here, even though I lose clarity at the outside. So we've got the technology now to be able to take advantage of cell phones, to take advantage of PDAs, even in locations where the industry has not yet put adequate bandwidth out. Let's then quickly go to a couple of examples of chronic diseases that has been talked about today so eloquently. What's key about chronic disease is it's a reversal of the previous model. Here the issue is resource access. This is really a key point. The care is really delivered by the consumer. The healthcare professional is a coach. But it's the consumer who's got to cope with that condition, and our job is to support the consumer. Now, one of the examples that we're going to talk about is that this is not new. This is the cover of a popular science magazine published right after Marconi talked about radio. It's called Radio Doctor, London, 1924. Consumers in 1924 were saying, we ought to be able to do this. It's very exciting that 85 years later we're getting around to it. So let's look at diabetes. People talked about interacting, getting hints. That's good, but also that somebody's got to make a decision about whether those sugars are valuable or not. And one of the things we haven't talked about is volume. There's about 300 million people in the United States. About 7% of them have diabetes. We tell diabetics to check their sugar between 1 and 7 times a day. Let's just take 3 as an average. That means there are 24 billion glucose values taken in the United States each year. Clinicians don't have time for this. This is why you have resistance to clinicians in many instances about chronic disease management. This is diabetes. Think about hypertension. Think about all the other chronic diseases that you want clinicians' office flooded with all this information. Don't forget, we need to be able to process that information. As an endocrinologist, I don't want my share of the 24 billion. I want there to have been processed information that is presented to me in a way that I'm comfortable looking at it, so I can see trends that instantaneously recognize. So it's not just capturing data. We can't lose sight of the fact that the data has got to be processed in a way that is meaningful to both the patient and to the clinician. There's also another interesting phenomenon about insulin pumps. Insulin pumps, you know, are one of the better ways now to manage diabetes. It gives a continuous insulin infusion. One of the things you learn is that it's an urban phenomenon. It's not a rural phenomenon. Why? Because if you ask the patients, they say, I don't think my doctor knows how to handle it. If you ask the rural doctors, they say, I'm not interested in getting involved in it because there would be such a small number of my patients who would have it that it's not worth the investment for me to put into the office to be able to have the expertise to be able to deliver it. So why can't we connect with both the doc and with the clinician for telesupport? And again, we can do that. The final case that I want to present to you is mental health support. As you know, returning soldiers, warfighters from Iran from Iraq and Afghanistan, the signature injury is traumatic brain injury. These are individuals who, because of blast exposure, are becoming less well able to cope with stress. So what does the VA do right now? Well, what the VA does is it has multi-session counseling and training sessions in coping for patients in VA hospitals. That's in a non-stressful situation. And then they send them home, where there's stress, but there's no support. So what we're working with them to do is to link VA hospitals that have the capabilities so that all of these veterans will have the opportunity to get their counseling, but then also to deliver services in the home, not just to the patient, but to the stressed caregiver, the spouse, the mother, the father, the sibling, who is in the home trying to work with these individuals. And once again, this is ubiquitous distribution, which is why we're talking about cell phones, which is why we're talking about wireless technology. So, although we've talked about barriers, and there are all kinds of barriers that the new initiative is going to address, part of what you've heard today, I think, with the real problem is recognizing and doing something about the possibilities. Not the possibilities of making what we've always done faster, more efficient, but about doing things that we couldn't possibly do without this wireless connectivity. And I would like to close with what I'm talking about in terms of creativity. Tele's been around for a while now, and we can do all kinds of examinations of patients at a distance, and we can do all kinds of things at home. But I was making rounds in the hospital one December a couple of years ago, and what I heard from the kids, we were covering, I'm an endocrinologist, we were covering the pediatrics for the holiday. What I heard from the kids is, I don't want to be in the hospital. I don't want to be in the hospital on Christmas Eve. He won't know where to come. That was the stress. You know who he was. He wasn't going to be able to come. Well, I happen to own a professional sensor. So what we did was we set up a direct wireless connection from each child in the hospital to the man. And the man was able to assure them that he knew where they were. You tell me how you fit this into the cost effectiveness equation. I don't know. But it did have something to do with healthcare. It did have something to do with wellness. We've got to expand the way we think about what we mean by maintaining health and maintaining wellness. And that's going to require creative thinking that doesn't necessarily fit into the reimbursement equation. One last point I would like to make, and this is a plea. This is the Internet Software Consortium's tracking of Internet activity in the United States since the Internet burst on the scene in 1994, 95, 96. And the figure up here is 500 billion events. point I want to make to you is that a medical student who matriculated in any medical school in the country in the fall of 2008 will take many years to be trained. As a matter of fact, that medical student is as far today from when the internet burst on the scene as from when that medical student will become a specialist in practice. Oh God, what are we going to be able to be doing with technology by then? But we're not teaching them the use. We're still talking about how we're going to do it better. At the same time that we're training clinicians, we're not even training them how to use what we can do today, let alone what we're going to be able to do with them 10 years from now. And so one of the other places that nobody's talking about today that we have to get into is the whole issue of health professional education, how to take advantage and include these technologies in this kind of thinking in the way they practice. And so addressing medical education of all health professionals as well as consumers is something that has to begin today, because it's already too late. There's a Chinese proverb that says if you want to read comfortably in a summer afternoon under a tree in the shade, when is the best time to plant the tree? And the answer is 20 years ago or today. And so I would like to suggest that we missed it here. We have to plant that tree today. Thank you.
Okay, last but not least, we'll hear from Thelma McClosky Armstrong. She is the director of the Eastern Telemedicine Network out of Billings Clinic in Montana.
Okay, great. How's everybody holding up this afternoon? I want to thank the New America Foundation for inviting me, and I really have felt at home in this room today. I feel a little bit like I was in the right side picture for most of the morning. How about you guys? But I'm warming up, so it feels better. I'm going to be brief today. My remarks are going to be brief. I have a question. Do we have any parents in this audience that have kids, young kids, 10, 12? Ever taken your child to a pediatrician? Yeah. Probably have somebody in here that may have a relationship with a cardiologist. We may have somebody in this room that actually is a caretaker of an aging parent. We may have somebody in this room that potentially has received oncology services in their lifetime or knows somebody that has received oncology services in their lifetime. If you live in Scobie, Montana, which is the north central part of the state, and you want to receive any of that kind of care, now mom who takes their kid to a pediatrician, you have to drive 340 miles to Billings, Montana. Now, let's think about this equate this to your life in the Washington, D.C. metropolitan area. It would be like driving from Washington, D.C. to Cleveland, Ohio to take your child, or you, or a member of your family to gain access to specialty medical care. And the other part of this is you may be driving on roads like this. This picture was taken in April, several years ago, right outside of Scobie, Montana. So when we talk about barriers to health care in Montana, distance, time, weather, access to care providers, there are no psychiatrists practicing east of Billings. It's 3/4 of the state. There's no cardiologists practicing in eastern Montana. So the access to specialty medical care is extremely limited. A critical access hospital in Culbertson, Montana has 4 beds. It's staffed by, most of the time their emergency room is staffed by a physician assistant. On occasion, they may have a traveling physician that's in that emergency room. So when we begin to talk about access to health care in rural and underserved areas of this country, we're talking about a whole different ballgame from what most of us know. I also want to say, though, that barriers are barriers, and you can experience these same barriers in an urban environment as well, and not being able to access the tight and timely critical access to care. So the Eastern Montana Telemedicine Network began in 1993, and it began as a opportunity to look at and to evaluate how interactive video conferencing could potentially increase access to medical and mental health care throughout central and eastern Montana. I had 4 partners when we started the network, 3 hospitals and a mental health center. And today, the Eastern Montana Telemedicine Network partners with 33 different types of healthcare and mental health care facilities. We serve central and eastern and northeastern Montana, northern Wyoming, and actually we just added our first site in North Dakota, which is in Williston, North Dakota. It's been a very interesting experience over the last 16 years. We've learned an incredible amount of lessons about how to provide telemedicine, but telehealth and telemedicine is addressing some of the critical barriers to healthcare in eastern Montana in many ways. In last year alone, we had over 80 healthcare providers provide service to our clients in eastern and central Montana and northern Wyoming. And you notice I said providers, healthcare providers, not physicians, because all kinds of providers use our network. Mental health professionals, physicians, neurologists, oncologists, cardiologists, nurse practitioners, physician's assistants, diabetic educators, dietitians, but all of them providing a continuum of care through interactive video conferencing to our patients on our network. Over 20 clinical services have been provided over our network in the last year, and we served over 3,000 patients. Now, 3,000 doesn't sound like a very big number probably to most people in this room, but you need to understand that the area that we're servicing, for most part, there are 5 people per square mile, and that in lots of the areas that we serve, there's 1 person per square mile. There are only 990,000 people in the state of Montana. So if you took Prince George's County and you put it in the state of Montana, all the people that lived in Prince George's County, our population would increase significantly. We also have 3 million cattle veterinary care, like Craig Barrett said, it's really pretty good in Montana. The other thing that's kind of interesting about what's happened from our perspective is 94% of the patients that we see over telemedicine on our network are retained in that local community, which means that strengthens that healthcare services in the communities that they're in. Lab, x-ray, all the tests, all the things that need to occur during a clinical exam are retained in that local healthcare facility. So it improves and supports the economics of the local community. The last number, which I find astounding, which is a number that's talked about very little in healthcare, is what it costs an individual out of his pocket to access healthcare. Not what we spend on insurance, not what we spend on copay, but what actually costs the individual. Those 3,000 patients saved over $1 million in travel costs, time away from work, funded money by staying in their local community, receiving care locally. Staggering number. So the other thing that we saw, the other thing that occurred as we developed our network is that because in 1993 we were one of 10 telemedicine networks in the country, we kind of brought interesting health information infrastructure into a community or a healthcare system. And as we introduced interactive video conferencing, interestingly enough, things have come in behind it. Remote diagnostic imaging, so teleradiology services, which has been a service that wasn't necessarily available in that community. And or the other thing that we've seen is the terrible out-migration and lack of resources for radiologists within rural areas. The ability to do more remote management of individuals with chronic disease, and we've talked about remote management a lot today. And the other thing that's been very interesting is the ability to have managed services much like clinical information systems and financial management software, so that we can leverage the ability to use the infrastructure that perhaps was purchased by a larger organization and push that out to our smaller partners within the region. So when I think about kind of what I need, and I said my comments were going to be very short today, when I think about what I need for the people that I serve in my region, what I need is access. I need access to, and they need access to families and friends, which sometimes are their caretakers. They need access to the best quality health information that they can get, and they also need access to their providers. And so what do I need to do that, or what do I need to help them have that access? And my mantra is bandwidth, bandwidth, and more bandwidth. And when I talk about bandwidth, and when I talk about broadband needs, it needs to be ubiquitous, it needs to be reliable, it needs to be scalable, it needs to be secure, and it needs to be cost effective. I cannot afford to pay $3,000 for 1 meg of pipe, which is something that I do pay for now. So it's critical to us as we think about moving forward in the future of telehealth and telemedicine applications, is to ensure that there's cost-effective availability of broadband. So, in closing, one of the things that I would like to say is I think we're moving and continue to move into an area where we know that we need to reform or transform healthcare, and that we are part of this digital revolution that is occurring. And my call to action today really is to make sure that we deliver the infrastructure that we need, we remove the policy barriers that keep us providing telemedicine and telehealth services efficiently and effectively. And I want to give you one brief example of this. CMS requires every physician that provides telemedicine services remotely to be credentialed and privileged in the remote site. So what that means to my organization is that I have to credential and privilege 80 providers and 33 healthcare facilities in my state, and the potential to do that in 60 more sites in my state. It is an incredible barrier to the deployment of telemedicine when that provider is already credentialed and privileged in the facility where they practice to provide that care. So we have to deploy the infrastructure, we have to remove the policy barriers, and we have to allow individuals, businesses, and groups to innovate and collaborate. Thank you.
And thank you so much for our telehealth panelists. We have run over time. If you have questions for these two very good panelists, please approach the table afterward. I'm going to invite our friend Carolyn up to make some closing remarks from the CTIA. But for the health policy program at New America, we'd just like to thank you so much for your time and attention, and also on behalf of Michael at the wireless program. We really appreciate the opportunity to talk to you about these important issues today. And I'll just close by saying, like Craig Barrett, we also believe that health IT is really about reducing costs and improving quality. And we also agree with him that we just need to take brave pills to get over some of the barriers that we face with that. And with that, I'll ask Carolyn to say goodbye to you all, but thank you very much.
I just have a quick 10-minute PowerPoint. Thank you all very much for being here. As the closer, I have the privilege of only taking about 30 seconds of your time. From the wireless industry's perspective, we are very excited to be part of this conversation. We will continue to be part of this. As my boss, Steve Larger, pointed out this morning, We are launching a series of initiatives next week out in Las Vegas at our big annual convention, and we're going to continue this dialogue working with people like New America and others in Washington to help do some education about what is currently happening right now, what is currently capable, and then what is the vision for the future. And I thought it was incredibly important that Thelma, actually being the last speaker, reminded us all that there are actually two pieces to this equation. It is the cost of providing health care, but we cannot forget about what is the cost to the consumer to take advantage of the services that are out there. And we believe, given the diversity of companies in our world, we have a role to play in building out the infrastructure to provide wireless ubiquitous coverage, to enable the provision of certain applications that you saw today. We also have companies that are developing those smartphones and other devices that will attach to these networks and enhance the user experience at both ends, both for the physicians as well as the consumers of the healthcare services. And certainly we also represent folks who are developing the applications that are continuing to drive innovation in our space across a lot of other sectors, including healthcare. So thank you all for coming. Hopefully you found this as interesting as we did, and we look forward to talking with you again.